neurology, pathology, intracranial hemorrhage. All right, so for the intracranial hemorrhages, this is like the bread and butter of neurology. I mean, majority of questions that you're going to be getting, you have to be thinking that it's going to be coming from intracranial hemorrhage. Okay, there's like so much on this. Okay, like I can't tell you how many questions I received on intracranial hemorrhages. So this is very high yield video. All right, so let's just get right into it. So we have the first hemorrhage is the epidermal hematoma. Okay, an epidermal hematoma is going to be located where the blood is between the skull bone and the dura mater. Okay, so it's outside of the meninges, okay, but it's inside the skull. Okay, so that is the first key thing that you have to know. All right, and that's why they call it epidural. Epi means above, and then dural means the dura. Okay, so it's above the dura. Okay, epidural hematoma. That's blood between the skull bone and the dura mater. Okay, now it's usually due to the rupture of the middle meningeal arteries. Okay, which is a branch of the maxillary artery. All right, and patients often present with like a skull fracture. All right, that is like hit near the temporal area. Okay, involving the pterion. Okay, the pterion is like the thinnest layer of like the skull, and it's on the lateral skull, like near the temporal region. Okay, so whenever they say like someone hit their head in like the temporal area, then like near the temples, they're talking about a potential epidural hematoma. Okay, because it usually involves the pterion. All right, and what happens is that once they hit their head, they'll pass out. Okay, but then after they pass out, they'll wake up. Okay, and so that's known as the lucid interval. But as they're awake and walking around and they initially regain full consciousness after hitting their head, they start to rapidly deteriorate after they wake up because the hematoma starts to expand and it leads to rapid deterioration. Okay, so remember, that's a scary thing. They're essentially the walking dead, okay, because they have this lucid interval, which is very odd to see. Okay, now, on CT scan, you have to know what it looks like. Take a look at what it looks like. It's going to be a biconvex shape that does not cross suture lines, okay? Biconvex shape that does not cross suture lines. Remember, since it's between the dura mater and the bone and the skull bone, okay, it's going to be kind of stuck between the skull bone, okay? That's going to give one area, okay, one location of the biconvex lens, okay? And the other area is going to be the dura mater, okay? But since the dura mater is just like the brain, it can push up against it and it can start to expand. So that's what gives it the biconvex shape of the epidural hematoma, okay? So take a look at that. You have to know that, okay? That is very key to understanding it. They will show you photos of the CT scans. You have to understand and be able to identify the biconvex shape shows epidural hematoma, okay? So quick run through. Epidural hematoma is blood between the skull bone and the dura mater. It's usually secondary to like being hit or hitting your head in the temporal lobe or temporal area involving the pterion, which is the thinnest part of the skull. And it causes the rupture of the middle meningeal artery. It's a branch of the maxillary artery. And initially you pass out, but then you regain consciousness, known as the lucid interval. Okay. And on CT scan, it's a biconvex shape that does not cross the suture lines. Okay. Now, one story that I helped my friends memorize this, one of the Parent Trap actresses, the mom in Parent Trap, she was on a ski trip in Canada. She was skiing. She hit her head while skiing. She hit a tree and she passed out. She regained consciousness and she said, call off the ambulance. I'm fine. I'm okay. Sure enough, she had an epidural hematoma that started to expand rapidly and she passed away. That's Liam Neeson's wife. I'm forgetting her name right now, but that's the actress. That's how she passed away, was due to the epidural hematoma. The way I remember this is Eminem, okay? Like the rapper. E M and M. So M and M. E, M, and M. Okay, so the E is for epidural hematoma. The M and M is for middle meningeal. Okay, so M and M, E, M, and M. E is for epidural hematoma. M and M is for the middle meningeal. Okay, that's kind of dumb, but that's just how I think of it. Next is the subdural hematoma. The subdural hematoma, it tells you where it's located. The blood is between the dura and the arachnoid space. Okay, so once again, it's below the dura mater. Okay, so it's usually secondary to rupture of bridging veins. And you're going to see this in patients who are very old, who have cerebral atrophy, so their brain starts to shrink when you get older. And when it starts to shrink, it can lead to, like, any type of severe movement of the brain can cause shearing of the bridging veins, okay? So increased age is a risk factor. Chronic alcohol overuse also leads to cerebral atrophy. So same thing. If you have an alcoholic, they have an increased risk of rupturing their bridging veins. The last one that they love to ask you about is shaken baby syndrome. Shaken babies have smaller brains. So when you undergo shaken baby syndrome, okay, a patient that's being abused at home, they can have rupture of the bridging veins, okay, rupture of those cortical bridging veins. All right, so those are the three things: increased age, alcohol use, and shaken baby syndrome for patients that are being abused. All right. Now, what are you going to see? You're going to see a crescent-shaped hemorrhage that crosses the suture lines. Once again, you're in the arachnoid space, okay, underneath the dura. So you're not bound by anything. So you're going to take on the shape of the normal contour of the brain, okay? So it's not going to be bulging like the epidural hematoma with the biconvex lens. It's going to be more of a crescent-shaped for the subdural hematoma, all right? The way that I remember this is the subdurine goes under the baby's bridge. Subdurine is for subdural, obviously. And then under the baby's bridge, baby is to remember the shaken baby syndrome. And then bridge is for the bridging veins. So the subdurine or submarine, the subdurine goes under the baby's bridge. All right. And for shaken baby syndrome, once again, the classic findings are going to be subdural hemorrhage, right? Subdural hematomas. Number two, you could see is retinal hemorrhages. Usually bilateral retinal hemorrhages is not going to be seen. But if they tell you that in a baby, you have to call CPS because there's probably a case of abuse. You can see posterior rib fractures because the patient is, think about the baby being grabbed by their parent and they squeeze the baby. They're going to squeeze and break the posterior ribs, which is an uncommon finding in patients. So that's going to be indicating abuse. And then the last one would be like inconsistent history. Okay. So that's what you have to think of for shaken baby syndrome. And once again, the subdural hematoma is one of the key factors. All right. Next is going to be the subarachnoid hemorrhage. All right. So for subarachnoid hemorrhage, this is very, very scary, okay? So what happens is that you get bleeding due to trauma or rupture of an aneurysm. Rupture of an aneurysm is what they love to ask about, okay? It's the most common complication of an aneurysmal subarachnoid hemorrhage is going to be vasospasm, okay? So a patient that comes in that has a rupture of an aneurysm leading to subarachnoid hemorrhage, we're very, very scared that they're going to have vasospasm in the brain. So what we have to do is provide them with nimodipine, which is a calcium channel blocker that prevents and reduces the risk of vasospasm, okay? So a patient that comes in with subarachnoid hemorrhage, secondary to a rupture of an aneurysm, all right, we have to give them nimodipine to avoid vasospasm. Very, very high yield. You have to know that, all right? Now, how are the patients going to present? They're going to present with sudden onset severe headache, okay, with signs of meningeal irritation. So what does that mean? That means that they're going to present with kind of similar to meningitis, okay? They might have like nuchal or neck rigidity. Very, very key to understanding this, okay? So they can present with nuchal or neck rigidity because of the meningeal irritation, and then they also have sudden onset severe headache, all right? What you're going to see on lumbar puncture is either blood or like yellow like type of fluid, okay? And that's xanthochromic lumbar puncture, okay? That's another word for that. So keep that in the back of your mind. Whenever they're talking about blood, bloody or yellow CSF from the lumbar puncture, it's xanthochromic, and it could be subarachnoid hemorrhage with the presentation of nuchal rigidity or neck rigidity, as well as like sudden onset headaches, okay? Very, very important. And remember, it's most likely secondary to a rupture of a berry aneurysm or a saccular aneurysm. So subarachnoid hemorrhage, I think arachnoid and aneurysm go together, okay? Now, this can lead to a communicating hydrocephalus because you have decreased drainage in the brain because there's essentially blood all over, okay? And that's what leads to the neck rigidity and all the other stuff, but it can also lead to communicating hydrocephalus because you have pressure pushing all over the brain and essentially pushing onto all the ventricles. But it's communicating because it's not obstructing anything. It's just making the ventricles smaller, okay? Remember the nimodipine to decrease or reduce vasospasm. That's the first thing you want to do for these patients, okay? Because like a couple days later, they can die from the vasospasm because it can lead to an ischemic infarct. Lastly, you have intraparenchymal hemorrhage. What you want to know about intraparenchymal hemorrhage is that it's usually secondary to hypertension, okay? But it can also be secondary to amyloid angiopathy, okay? So intraparenchymal hemorrhage is caused by a plethora of things. If you see hypertension, amyloid angiopathy, or an AV malformation, arteriovenous malformation, those are the three common things that cause intraparenchymal hemorrhage. Okay, so I'm going to repeat them. Hypertension, amyloid angiopathy, and AV malformations. Okay? So let's start off with our hypertension. So if we have hypertensive hemorrhages, it's known as Charcot-Bouchard microaneurysms, okay? And so that's going to be seen in the lenticular striate vessels, leading to intraparenchymal hemorrhage. So, right, we already discussed the lenticular striate arteries causing the lacunar infarcts. Well, that can be caused by the intraparenchymal hemorrhage. It's known as the same thing, okay? Because when it's caused by hypertension, it's going to be leading to a Charcot-Bouchard microaneurysm, okay? And that most commonly affects the lenticular striate vessels, which we discussed in the stroke video, okay? Next is AV malformations. So whenever they say like a bag of worms, think AV malformations. Like if they show you a photo of the brain and they say like, oh, it looks like a bag of worms, then you think that they're talking about AV malformations, okay? A cavernous hemangioma is like essentially an AV malformation. So if they say there's a cavernous hemangioma, what are they at an increased risk for? They're at an increased risk of intraparenchymal hemorrhage, okay? So think about that. All AV malformations are at an increased risk of spontaneous hemorrhaging, okay? Whether that might be due to cavernous hemangiomas or any type of AV malformation, okay? And then lastly is our cerebral amyloid angiopathy, okay? Whenever you see an elderly patient with lobar hemorrhage, so like a random intraparenchymal hemorrhage or lobar hemorrhage, they're the same thing. In an elderly patient, the number one cause is going to be cerebral amyloid angiopathy, okay? So keep that in the back of your mind. It's the most common cause in elderly patients. They can get recurrent lobar hemorrhaging or strokes in the older population due to the amyloid angiopathy. All right. So overall, that's our intracranial hemorrhages. I'm going to run through it real quick. Epidural hematoma. This is going to be middle meningeal rupture, secondary to the maxillary artery. It's blood between the skull bone and the dura mater. It's going to look like a biconvex lens on CT that does not cross suture lines. It usually occurs due to trauma in the area of the temple involving the pterion bone. And usually after initial loss of consciousness, you regain consciousness, known as the lucid interval state. But rapid deterioration occurs after that due to hematoma expansion. Next is going to be the subdural hematoma. Subdural hematoma is due to rupture of the bridging veins. The risk factors are increased age, chronic alcohol use, and shaken baby syndrome. The blood is going to be between the dura mater and the arachnoid space. It's going to show as a crescent-shaped hemorrhage, and it crosses suture lines. Okay. Next is subarachnoid hemorrhage. The patient's going to present with nuchal rigidity or neck rigidity and sudden onset severe headache. On lumbar puncture, they can have bloody or yellow fluid. And the patient's usually going to be presenting due to a rupture of an aneurysm, likely a saccular or Berry aneurysm. All right. You have to give the patient nimodipine after the rupture of the aneurysm so that you can prevent and reduce risk of vasospasm, which can lead to sudden death. Subarachnoid hemorrhages can cause communicating hydrocephalus due to blood all over the brain, okay? Last is intraparenchymal hemorrhage. The three main causes are hypertension, which is associated with Charcot-Bouchard microaneurysms, which can lead to lenticular striate vessel strokes or lacunate strokes. Number two is going to be amyloid angiopathy. If you see an elderly patient with recurrent lobar hemorrhages or intraparenchymal hemorrhages, you know that it's going to be amyloid angiopathy. And last is going to be AV malformations, whether it might be a cavernous hemangioma or any other AV malformation. It can look like a bag of worms on imaging that can lead to intraparenchymal hemorrhaging. All right, that's all for the intracranial hemorrhages. If you have questions, please reach out.